So hi guys, today we are going to talk about fungal infections in the skin. This can be applicable to other parts of the other specialties also, but this is going to focus more on skin today. So when we talk about fungal infections, I tend to separate them out with hyphae and yeast forms. I'm going to talk about that, but I just want to, before I start the lecture, the disclaimer is that I'm not a microbiologist and some of the fungal forms mentioned in the talk may not be accurate. But this is how I think in my brain. So I wanted to show you the algorithmic approach I normally take so that you can build the same algorithmic approach in your brain that will help you remember all the different fungal infections in a much easier way. So when we talk about fungal infections, the way I look at them is like whether it is a superficial fungal infection or is it a deep fungal infection. And when we're talking about superficial fungal infections, we are talking about the infections that are mostly limited to the stratum corneum. And only one example, that is the Majocchi's granuloma, will have a little bit of a dermal component. In the superficial fungal infections, the main thing that we want to look for in the stratum corneum is, do we just see hyphae or do we see hyphae and spores? If we see both the hyphae and spores, especially on the HNE, then that is Tinea versicolor. The hyphae of the dermatophytosis is usually not visible on the HNE, so you always have to do the PAS stain to see the hyphae, and these can be pigmented and non-pigmented. The pigmented conditions are seen on the acral site, and that is Tinea nigra. And the non-pigmented ones is the dermatophytosis that we often refer to as Tinea infections, for which we need the PAS or the GMS to see the fungus often. Sometimes you might see them on the HNE, but definitely the PAS will be much more accurate. Candida and then the Majocchi's granuloma. So these would all be included in the superficial fungal infections. And when we talk about deep fungal infection, because there are so many of them, the easier way to remember them is dividing them first into pigmented, non-pigmented, and then whether they are yeast and hyphal forms. So in the pigmented ones, if you just have the yeast form so that you just see the copper pennies, then that is Chromoblastomycosis. But if you see both the copper pennies and the hyphae, then that is Phaeohyphomycosis. In the non-pigmented form, it can be only yeast, which are the more common ones that we see. And this yeast can be intracellular only, or it could be intra and extracellular. For the intracellular only, the more important one is histoplasmosis, which is the more common one. But the other one that we need to remember when we are talking about deep fungal infections is also Penicillium. And when we talk about the yeast being both intra and extracellular, that is within the interstitium as well as within the giant cells and the macrophages, we are talking about the group of infections that include Cryptococcus, lobomycosis, Blastomycosis, Paracoccidioidomycosis, and Coccidioidomycosis. So let's start with the superficial fungal infections. So here's a nice clinical example of an 18-year-old male that presented with mildly pruritic, expanding, red, scaly plaques of his left thigh. So you can see the nice annular lesions that are here basically. So clinically it will always come in as rule out fungal infection. So here's the slide that we see here. So normally we would need the PAS stain to look for fungal infection. So we should always do the PAS. But in this one, I think we can even see it on the HNE. So you can see the fungus here actually. And the other feature that many books will also talk about is the sandwich sign. So by the sandwich sign, they mean the orthokeratosis that you see here, the orthokeratosis and the parakeratosis and the orthokeratosis. So this is like a sandwich sign where you see the fungus in between them actually. So you see ortho and parakeratosis in between layers of hyperkeratosis. And this fungus is easier to see in this one, where you can see the fungus here basically. So there's almost the fungal party going on. So you can see all these hyphae forms here and often associated with a lot of neutrophils basically. But there many times you might not see the neutrophils, but if you see neutrophils, that is the first thing to think about, fungus and then do a PA stain, and many times you will save the patient a lot of treatment that is not needed, and which would be a very straightforward treatment by treating the fungus. When we move on to the, so that is Tinea corporis or dermatophytosis, however you want to call it. And then Tinea nigra is usually on the acral sites where you see this pigmented hyphae in the stratum corneum. These are brown and black pigmented hyphae in the stratum corneum, usually on acral skin. So that, and when we already talked about Tinea versicolor, so this usually presents with hyper or hypopigmented annular, finely scaly, thin plaques on the upper trunk. You can see this plaques here on the upper trunk, so they are usually hypopigmented. And the biopsy, even on the HNE, you will be able to see the fungus. So here you can see the hyphae that is known as the spaghetti, and then the small round balls that you see, that are the meatballs. So the spaghetti and the meatball appearance is very classic for Tinea versicolor, which is usually also seen on the HNE stains actually. So you do not need the PA stain, but if you do a PA stain, you're going to see them much more easily. So here we can see them on the PA stain. A GMS or PA stain is going to highlight both the spaghettis and the meatballs. So this is the spaghetti, and here are the meatballs that you see here basically. So that is Tinea versicolor. When we talk about Majocchi's granuloma, that is one that you are usually going to see in the dermis. So usually it looks like a suppurative and granulomatous inflammation that is usually associated with a hair follicle. So sometimes it might look like a ruptured hair follicle, but you can see all these neutrophils and lymphocytes and macrophages and giant cells. And then when you look very carefully, you see this big fungal ball here actually. So there's a lot of hyphae here basically. And the PAS is going to make seeing this very easily. So you see a lot of suppurative and granulomatous inflammation in association with fungus in a fungal hyphae within the dermis, and that is Majocchi's granuloma. When we talk about candida, it is usually associated with a mucocutaneous infection in the mucocutaneous biopsy. So let's go here. Oh, this is here. So here you can see no granular layer. So we know we are dealing with a mucocutaneous lesion. And then even on the HNE, some of these fungi are easily visible. But if you do a PA stain, then it's very easy to see them. And when we talk about candida, it is usually the vertical orientation of the fungus that helps the histological diagnosis, because you can see this fungi. Let's find them. So here. So we see the vertical oriented hyphae running, so vertically oriented to the epidermis. So you see the vertically oriented hyphae in the stratum corneum, although this is mucosa, so it wouldn't be technically stratum corneum, but you can see all of them vertically oriented to the mucosa. And that is very classic for candida. But again, the culture is that is going to be much more specific when you want to call it candida. And then now we'll move on to the deep fungal infections. So we already talked about deep fungal infections being divided into non-pigmented and pigmented. So we're going to talk about the pigmented ones first actually. So non-pigmented yeast forms, which are first intra and extracellular. So the first case that we'll talk about, this is a 45-year-old female with a patient of HIV, which has a very low CD4 count, and she presents with this new facial rash. And when we look at these biopsies, so the deep fungal infections are usually associated with the suppurative and granulomatous inflammation. So you usually see a lot of neutrophils, you're going to see a lot of macrophages, you're going to see a lot of giant cells associated with the inflammation. So whenever you see a suppurative and granulomatous inflammation, you always have to think of a deep fungal infection, and the other differential diagnosis is an atypical mycobacterium. So you're going to go high power and look into this, and then you see all these round yeast-like organisms basically. So the important thing is to decide what is the size of these cells, of these yeast. So when we compare that to a lymphocyte or a red blood cell, so here you can see the organism. They're very similar in size to a lymphocyte actually. So when they are similar in size to a lymphocyte or a red blood cell, that is around 7 to 10 microns, then we're either talking about Cryptococcus or sometimes lobomycosis, but it is usually Cryptococcus. So these are usually encapsulated budding refractile yeast around 5 to 15 microns, and then they have a very prominent capsule around them. And this capsule can often be highlighted by mucicarmine. So if you do a mucicarmine stain, you can actually highlight the capsule. In the same category, so clinically, we will say, we already saw this picture where the patient in Cryptococcus presents with this painful skin color to red papules. In the same category, we have Blastomycosis, which is again a non-pigmented yeast form. These usually present with this cutaneous involvement that are verrucous or ulcerative lesions. Blastomycosis is more common in the Midwestern and Southeast part of USA and around the Mississippi and the Ohio River Valley actually. So when you look at the histology here, so again, we have the background of the granulomatous and suppurative inflammation. This is also associated with some pseudoepitheliomatous hyperplasia. So many of the deep fungal infections are going to show you this pseudoepitheliomatous hyperplasia on the top, and then the suppurative and granulomatous inflammation. So again, you should immediately think of fungal infections or atypical mycobacteria. And then you go high power and you see all these organisms here. So you see this thick capsules of the organisms. This is 3 times the size of the Cryptococcus, so around 20 microns. So they are around 15 to 20 microns, so 3 times the size of the Cryptococcus. And they have this thick refractile wall, and they often have broad-based budding. So they might show you like 2 of them simultaneously with a broad base actually. And they are present both extracellularly as well as within some of the macrophages and the giant cells. The next one is lobomycosis. So clinically this presents with this keloidal-like plaque. So it is also known as keloidal blastomycosis that can become verrucous or ulcerated over time. And they can occur on the ears, elbows, or the ankles. So this is a very beautiful slide where you're going to see this again. We talked about the suppurative and the granulomatous inflammation. So you'll see a lot of granulomas, so giant cells, macrophages, and within these macrophages, you see this organisms here basically. So they have the same size as the Cryptococcus. But the typical thing that we see in lobomycosis is that they have this pop bead-like appearance. So they are in chains actually. So this pop bead-like appearance is very characteristic of lobomycosis in a background of this granulomatous inflammation. And when you do the GMS stain, it becomes very obvious where you can see them nicely forming pop bead-like or chain-like appearance basically. So you can see all these chains very easily on the GMS. And that makes the diagnosis very easy that this is lobomycosis. Moving on to the next one is Coccidioidomycosis. So this is again common in more southwestern part of the US, also called desert fever. They usually present with this disseminated lesions that involve quite a large part of the body, and the primary lesions are usually like a painful form nodules basically. And they can sometimes present with EM-like rash that can be seen in the acute disease. So again, the same background, suppurative and granulomatous inflammation. So you can see all the granulomas, you can see the inflammation here. And then when you hone down, you can easily see the organism. So you see this big organism here that is usually 10 times the size of the lymphocyte now. So this one is 10 times the size of the lymphocytes, around 80 microns. And they have multiple endospores basically. So these are usually very small, 1 to 4 microns, and they have multiple endospores that can be seen in the sporangia. So this is a sporangia with multiple endospores, and they are present both with, so you can see this is present within the giant cell, and then there was another one somewhere here that was present outside of the giant cell. So they can be present both intracellularly as well as extracellularly actually. Paracoccidioidomycosis is also known as South American blastomycosis. They can affect both the skin as well as internal organs. In the skin, they present with these keratotic papules, which are ulcerative and sometimes painful. And they are usually more common around the nodules around the mouth and the nose. These two slides were provided by my good friend from Brazil, Geronimo. So these are both this slide and the next one, he's provided them. So here you can see that again the same background where you have the suppurative and granulomatous inflammation. So there's a lot of inflammation, necrosis, granulomas, giant cells, everything is here. And then when you go zoom into the slide, you will see this organisms here. So a lot of these small organisms here. So when we look in the books, they talk about that mariner's wheel with this Paracoccidioidomycosis. So you can see all these round organisms here that are very classic for this organism. And the mariner's wheel is more easily seen on the GMS actually. So when you look at the GMS, you can see this mother and daughter sporangia basically. So the mother and then the daughter, and that is what causes the mariner's wheel like appearance actually. Most of them have it here on the GMS basically. So that is very, very classic for Paracoccidioidomycosis. The next one is sporotrichosis, which presents with the sporotrichoid-like lesions on the forearm. So when you see this, you have to think of sporotrichosis, leishmaniasis, atypical mycobacteria, all of these other infections. And this can also be disseminated, but when they are on the fixed cutaneous, on the skin, they present with verrucous fixed lesions when they are fixed. And in the lymphocutaneous form, which we see here, we have this lymphatic spread of painless red nodules. Histologically, it's very difficult to find these organisms histologically because they are very, very small. But again, the background that you see here, where you see a lot of neutrophils, you see a lot of plasma cells, giant cells, so you have that suppurative and granulomatous inflammation that should immediately make you do the PAS and the GMS stain. And when you do the PAS and the GMS stain, it's easy to find these organisms, and you can see them here actually with the GMS stain. So you see all these rounded structures. So these are usually cigar shaped. Some of them are cigar shaped. They are usually 2 to 8 microns, and some are round, which are 4 to 6 microns, yeast forms actually. And you might also see some stellate neutrophilic abscesses surrounding the granuloma. So that has been described, even asteroid bodies may be noted. So all of them have been described with sporotrichosis. But they normally present with this cigar shaped and round yeast forms that are very easily seen on the PAS and the GMS, but very hard to see on the HNE basically. So when we look at, when we want to make the diagnosis, like this is size is very important. So the Cryptococcus we talked about being the same size as the red blood cell or the lymphocyte. The lobomycosis is usually the same size as the crypto, but has the pop bead appearance. The blasto is 3 times the size. So here's the blasto, which is the 3 times the size of the crypto, and then the coccidio, which is 10 times the size of the crypto. So crypto, lobo, blasto, and coccidium. So next we'll move on to the yeast form, which are intracellular. So the more important one is the histoplasmosis, and then the uncommon one is the Penicillium. So here's a nice yeast forms intracellular. So here again you can see some pseudoepitheliomatous hyperplasia on the top, which may be present, may not be present. And in the dermis you see the suppurative and granulomatous inflammation. So again, you have to think of fungus and atypical mycobacteria. And then when you zoom into the slide, you're going to see this organisms, intracellular organisms within the cell actually. So these are intracellular cysts around 2 to 4 microns. You can see that they are evenly distributed and they are surrounded by a pseudocapsule. And the pseudocapsule can easily be highlighted by the PAS and the GMS basically. And in the background, you see a lot of suppurative and granulomatous inflammation. So whenever you're talking about histoplasmosis, this can be the cutaneous form, which is rare. It can occur from the direct inoculation and it usually presents with this ulcer or nodule that is associated with lymphadenopathy. So the main differential diagnosis when we talk about histo is leishmaniasis actually. So leishmaniasis can also look very similar. So you can see this. So there are all these organisms here that you see here that are the leash organisms. So they are not usually evenly distributed and they tend to have this marquee sign at the periphery. But another very easier way to make the diagnosis is you can see a lot of mixed infiltrate in the background. So you can see plasma cells, lymphocytes, macrophages, less giant cells as compared to what you see in histoplasmosis. And then obviously if you're in practice, you're going to do the stains. The histoplasmosis is a fungal organism. So it is easy to make the diagnosis because they will stain with the fungus, and the leishmania is going to stain with the Gimsa stain. It will not stain with the PAS or the fungal or the GMS stain. So Penicillium is the next one that we are going to talk about. This is more common in Southeast Asia. The disease almost exclusively seen in immunocompromised individuals when the count is very low in HIV patients, and they present with these papules that have the central dell almost like molluscum. So again, these are intracellular organisms in the background of a suppurative and granulomatous inflammation. And when you go high power, you will see these organisms here. So this slide is a little bit faded, but this was the only example that I had. And you can see all these intracellular organisms here basically. So all these are very intracellular, quite a few within the cells actually. So these are intracellular yeast. They're usually 3 to 8 microns. Some are elongated. You can see some of them are elongated. And if this is scanned at 20x, so if you have a glass slide, it is much easier to go at 40x and see them. And the one feature that they talk about is you may see some septations within them actually, because they divide by binary fission. So that helps you out sometimes when you have a slide that you can go up to 40x and look at them actually. So moving on to now the pigmented form. So we're talking about the yeast and the one that only present with yeast and the other one that shows both yeast and hyphae. So we're talking about pigmented yeast forms. So again, suppurative and granulomatous inflammation, a lot of granulomas, and then when you go high power, it is very easy to recognize these copper pennies here that you see here. So you see all these copper pennies here. So this is Chromoblastomycosis actually. All these medlar bodies, copper pennies, whatever name you want to give it actually. And so these clinically they present as red, purple, verrucous papulonodules on the lower extremities, but they can occur on other parts of the body. And when we talk about the Phaeohyphomycosis, they usually present with both the pigmented yeast and so both the yeast and the hyphae form. So here again you can see that the background is again suppurative and granulomatous, but when you go high power, you can easily see this pigmented fungi that are, some of them are forming hyphae here. There you can see the hyphae here, and some of them are the round spores here basically. So you can see the copper penny like here structures here, but also the hyphae here, and when you see both of them, this is Phaeohyphomycosis. So Phaeohyphomycosis is caused by more than 100 different kind of fungal species, mostly in the immunocompromised patients. And people who are studying for the board exam, they have to remember the CARD9 mutations. So patients that have a CARD9 mutation tend to present with tend to they have a higher chances of developing a phaeohyphomycosis like or a cyst or infection. So moving on now to the the phaeohyphomycosis, we already talked about the immunohistochemistry. So clinically they present with ulcerated, necrotic, progressive lesions in the immunocompromised or red cyst-like lesions in the immunocompetent host. And moving on to the hyphae forms which are non-pigmented. So now we are talking about the mucor and the Aspergillus. So these are hyphae forms which are non-pigmented. So they are divided into two categories. One we have where they are called the hyohyphomycosis, which includes Aspergillus, Fusarium, and Pseudoalasteria. And then the other one is the zygomycosis, which includes Mucor, Rhizopus, and Apsidia. So the easiest way to recognize are these are septate and these appear to be very hollow. So these are non-septate and they appear very hollow. They talk about the 45-degree branching, which is not always true, but if you see one that has 45-degree branching, it's more chances that this is the hyohyphomycosis, and these are supposed to have almost 90 degrees branching basically. So here we can see again, there's a lot of inflammation here in the dermis, and then around these blood vessels, you can see the long hyphae with the septae actually. So these are narrow septate hyphae with acute angle branching and the background of necrosis with focal foci of vessel. So these are invading the vessel actually. So this is quite common with the Aspergillus where you see them invading the vessel. And when you do the GMS stain, they are easy to recognize because then you can nicely see the narrow septate hyphae actually. So these are very narrow. And then if you zoom into you may even see the septations actually. So let's look here. So you can even see the septations actually. And they have this 45-degree branching. So this is Aspergillus, but can also be the other two types of organisms. So Aspergillus, they usually present with a fungal ball. They can also, the cutaneous findings can be very variable and they are usually angioinvasive. You can see this purplic necrotic nodules, which is a very nice presentation of Aspergillus. And when you come to the mucor, they usually occur in diabetic patients, immunocompromised patients, and they tend to invade the blood vessels, and because they are invading the blood vessels, they will cause they compromise the vasculature, and because of the compromise of the vasculature, the skin tends to become necrotic. So it's usually a background of necrosis. And then when you go high power, you're going to see this organisms that appear very hollow actually. So you can see that these are hollow type organisms and they do not tend to have the septations that you saw with the Aspergillus. So hollow organisms have no septations. And when they are cut in a transverse section, you can see this hollow tube-like structures basically. So this is the entire tube, and when it is cut in this, you will see this tube-like structures. In this slide, they are even present in the fat. So here you can see in the fat, these tube-like structures that are hollow and some that are cut in a transverse fashion. So this is mucor. So I think that was the last case. So mucor can present with, in the cutaneous disease, they usually present with this black necrotic ulcer with violaceous border, but they can also present with pulmonary disease, GI disease, or disseminated disease. So for any of these cases, if you want to see additional clinical images, you want to see additional digital slides, you just log into publication.pathpresenter.net. And then you click on My Books, you'll see Dermatopathology for Residents, which is a free resource written by 65 different authors and has a ton of information about each diagnosis. Thank you and see you next time.